Hi guys, good evening. This is Dr. Sushma, your anatomy educator for today's class. And from today, we are going to start neuroanatomy. Neuroanatomy is one such subject which is, I think, is the most fascinating thing, uh, because here you will definitely enjoy how everything comes together towards the end of these 7 classes that we have planned to to cover neuroanatomy. And towards the end of this class you will see how beautifully everything converges and everything comes together, and it will really help you with revision. And I hope my upper limb classes were helpful to you. And I am pretty sure that all these classes that we are conducting here at Oracle of neuroanatomy will definitely help you to ace your examinations. Yes. And we at Oracle offer live classes, recorded sessions, notes, and multiple choice questions. In live classes, you will have an educator who will teach you live and who will clarify your doubts live, and you can log in and then you can ask and you can get all your doubts clarified. In recorded sessions, you will have access to all our recorded videos, which you can watch and then get. If you have any other additional doubts, you can always get them clarified as well. And you have notes which are based on recent CBME curriculum and the MCQs, which will help in the next examination for us, right? So all these 4 things will help you to stay on track and, of course, ace your examinations. And you can also book a personalized counseling session with our mentors who will help you, guide you, and clarify any doubt, academic or otherwise. And this is the plan that we have in our mind right now, and this is what we have in the pipeline, where we'll cover CSF and blood brain barrier, brainstem, midbrain pons, and so on. And I'm pretty sure that you will definitely ace your examinations. And with the live classes, you can watch them, you can take notes, and this should be one-stop solution for everything, for all your doubts. Yes. In the first class, we are going to start with cerebrospinal fluid. Guys, in cranial cavity, we have 2 tissues. We have brain and we have cerebrospinal fluid. Brain and CSF are the only 2 things that are there inside the cranial cavity, right? Now, why do we need to have CSF in the first place? Why do you think there is a fluid around the brain inside the cranial cavity? And first point. Second point, what are the functions of CSF? Third point, how is it getting produced? Fourth point, what is the applied aspect of having this? What is the applied aspect of knowing about CSF in the first place? Okay? All these points we will cover in today's class, right? Now, what is CSF? Cerebrospinal fluid is a modified tissue fluid, correct? Any fluid in the body obviously resembles plasma, but CSF is a modified tissue fluid which is present in the cerebral ventricles, spinal canal, and subarachnoid spaces that thus bathes the entire nervous system. Meaning, if you have your brain like this and the cranium here, the brain is entirely covered by the cerebrospinal fluid. Okay. Now, important point to note over here is CNS is devoid of any sort of lymphatics, correct? And the CSF replaces lymph here. Whatever the functions of lymph as a tissue is replaced by CSF only here. Okay. Brain is a very sophisticated organ, guys. I mean, brain has its auto blood regulation, brain has its auto cerebrospinal fluid regulation as well, correct? So because of the sophistication of the brain, so we have a modified tissue fluid which is called as cerebrospinal fluid. Now, what is the site of formation of CSF? About 2/3 of the CSF originates from the choroid plexus in the fourth ventricles, mainly in the 2 lateral ventricles, right? About 2/3 of the CSF actually comes from the choroid plexus in all 4 ventricles, and but the 2 lateral ventricles is where the maximum amount of CSF gets produced, right? Now, I hope you have a sort of clarity about what ventricles are. Ventricles are the empty spaces that we have, isn't it? I hope you know about the 4 ventricles. I'm assuming that all of us have some basic idea about about neuroanatomy, and we're just doing a quick recap. Okay, I really don't have time to explain what ventricles also are, but I hope you know about ventricles, and we know the two lateral ventricles, right? And that is where the CSF is actually getting produced, right? And additional small amounts of tissue is also secreted by the ependymal surfaces of the ventricles and the arachnoidal membranes, and small amount comes out from the brain itself. Correct. The brain itself produces a small amount of CSF through its perivascular spaces and surround the blood vessels entering the brain. All right. Main takeaway point from this slide is number one point: where is the CSF getting produced? It is getting produced mainly in the two lateral ventricles. Two lateral ventricles. Okay. Yes. Then what are choroid plexus? You must have heard the word choroid. Where else do we hear the word choroid? Yes, we hear the word choroid in eyes also. What do they secrete over there? They secrete, what do they secrete? Aqueous humor. Yes. The ventricles contain certain capillaries which are derived from the internal carotid and posterior cerebral arteries, right? Now, choroid plexus, the name plexus, we have heard again. Plexus meaning any network, any bunch of things which are together is called as plexus. We have brachial plexus also. So, choroid plexus is nothing but bunch of such capillaries which are projecting in the cavities of the ventricle, which is covered by cubical epithelium of ependymal cells. Okay. And now these endothelial cells of the capillaries are not as flat. Generally, if you look at how the endothelium is. Now, again, guys, come into the histology here. What is endothelium? Where is it present? You must have, have seen different layers, right? There is, if you look at, there is epithelial surface, and then there is a basement membrane, then you have the endothelium, right? So these endothelial cells of the capillaries are not flat, but they are granular and cubical with mitochondria and vacuoles, meaning that they are active. There is some active metabolic process that is going on in these cells, right? What is the take home point over here? The endothelial cells in choroid plexus are not dead. They are not as flat, or they are not dead, or they're not doing any activity. Rather, they are granular cubicle and they have mitochondria, vacuoles, indicates that there is an active metabolic process in the cells. Right. Now, these choroid plexus projects into the temporal horn of the lateral ventricle, the posterior portion of the third ventricle, and roof of the fourth ventricle. Okay. I hope, again, I'm repeating, where the location of the third ventricle is. The location of the third ventricle where we have the mammillary bodies, and then the I just hope you know where exactly you're getting a visual of third ventricles, lateral ventricles, and then the fourth ventricles, aqueduct of Sylvius. I hope you're getting an idea. Are you getting an orientation as to which area of the brain I'm talking about? Right? You have the third ventricle, which actually projects like this, and then we have the lateral ventricle, right? I hope you are getting this orientation. Yes. So these are the choroid plexus. These are the choroid plexus. As you can see, these are the secretory cells. Okay. Yeah. Now, mechanism of formation. There are two theories wherein the secretion is a major process and the filtration is a minor process. Secretion of fluid by the choroid plexus depends mainly on the active transport of sodium ions through the epithelial cells that line the outsides of plexus. Look at this. These are the secretory cells which are lined by this epithelium, and the sodium transport actually determines the secretion. Sodium ions in turn pull along the large amounts of chloride ions as well, because the positive charge of sodium ion attracts the negative ions charge, that is chloride ions charge. The two of these together, they increase the quantity of osmotically active sodium chloride. Guys, wherever sodium is there, it pulls water. Right? Wherever sodium is there, it pulls water. Now, because there is a negative charge as well, both have formed together to form a sodium chloride compound, which then causes immediate osmosis of water through the membrane. Thus, it provides the fluid of the secretion. As simple as this. But I hope you've understood the point here. Mainly, it depends on the active transport of the sodium ions through epithelial cells. Once the sodium goes out, it actually then combines with chloride. Then wherever sodium is there, it pulls the water, and water through osmosis provides the fluid of the secretion. I hope this is understood. I hope you also have an idea in physiology, in general physiology, they talk about which are the intracellular and extracellular cellular ions. Just a quick question, is potassium an intracellular or an extracellular ion? It's a question for you, right? Less important transport processes move small amounts of glucose into CSF and potassium, which is not very important. But the most important point over here to remember is the rate of formation, correct? The rate of formation is about 0.35 ml per minute in adults, or 20 ml per hour, or let's say around half a liter per day. You can remember this value, that is, it's about half a liter per, 500 ml per day. I'm very sorry, guys. It's about 500 ml per day, not half a liter. I'm very sorry. Sorry, correction here. And the rate of formation is about 500 ml per day. Yes. Now, volume and the composition of CSF. The total volume that is there inside the cranial cavity is just about 100 to 150 ml. And the specific gravity somewhere varies between 1.002 to 1.009. This value is again very important, guys, right? CSF is just not an ultrafiltrate of plasma, as you know, whenever you hear the definition of CSF, the first thing you write is CSF is an ultrafiltrate of plasma. No, it's not. The formation of CSF or the composition of the CSF is very different as compared to plasma. How is it different? We'll see now. CSF has very lower concentrations of protein, calcium, potassium, bicarb, urea, glucose, phosphate, but it has higher concentrations of sodium and chloride. Why sodium and chloride is high? Because it draws water, and that is what is providing the fluid content for CSF. If you've understood how the CSF is getting produced, writing the composition is not difficult. Except for sodium and chloride, everything else, whether it is protein, calcium, and everything else, is reduced in CSF. Okay. Now, this is the normal composition of CSF, where the color is clear as water. If you look at, once you do a lumbar puncture, when you go into your internship, you can ask your resident to teach you lumbar puncture. Once you do lumbar puncture, when the fluid starts dripping in, you can see that it is clear as water. Any change in the color of the fluid will tell us that it's an abnormal CSF. Cells obviously is 1 to 5 cells only, right? Any increase or decrease in cells indicates some sort of pathology. Protein is about 20 to 40, glucose is 50 to 80, chloride is 700 to 750, sodium is around 330, calcium is around 5.3, phosphate is around 1.8, bicarb is around 40 to 60, urea around 10 to 30, and potassium is about 12 mg. So I don't think this, the chemical composition of CSF is important per se in with respect to anatomy, but this definitely can be asked in physiology. Okay, this is a physiology topic, right? Now, the chemical composition of a sample of CSF drawn from a normal subject depends upon the site of withdrawal of fluid, correct? Now, again, why is it I'm specifically mentioning about this is because the ventricular CSF is very different as that of cisternal or spinal fluid, because ventricle is where the CSF is actually getting produced. Agree? Ventricle is where the CSF is actually getting produced, and as it goes through the arachnoid cisterns and granulations, then of course, then it enters into the spinal cord as spinal fluid. Then some components get added to the fluid across the spinal arachnoid membrane as well. Correct? Lumbar CSF, if you look at the total protein is around 10 to 40, glucose is around 50 to 80, chloride is around 10 to 750, but the ventricular CSF total protein is a little higher, glucose is a little higher, and chloride is also a little higher, right? Now, what is the CSF pressure? The normal pressure of CSF when one is just lying down in horizontal position is about 130 mm of water. It is regulated by a balance of between the daily production and absorption, right? How much ever is getting produced, if that much is getting absorbed, what happens then? Then the pressure becomes normal. Production increases, absorption decreases, CSF or the pressure inside the cranial cavity raises. Correct? Yes. The rate of CSF formation and the resistance to its absorption through the arachnoid villi under normal circumstances, formation is around 500 ml, as I've already said earlier. Next, cerebral blood flow is again one of the factors that increases the CSF pressure because of an concomitant increase in the cerebral blood volume. Correct? I mean, it makes sense now. The more blood enters, more pressure increases. Arterial blood pressure, this does not affect the CSF as much. No, it does not, it affect the CSF as much, but within the normal range, there is an auto regulation. However, it does produce a systolic diastolic fluctuation in CSF pressure. Venous pressure, again, should be whatever the pressure that is there, intracranial venous sinuses should be lower than that of the CSF for it to allow it to flow through and continuous reabsorption in the arachnoid villi. Certain pathologies, this pressure relationship gets disturbed and that increases the CSF pressure. Okay. Now, circulation of CSF. How the circulation of the CSF is actually taking place? It is actually aided by the cilia on the ependymal cells that are lining the ventricles. Then the fluid secreted in the lateral ventricles passes first into the third ventricle through the interventricular foramina, and then addition of small amounts of fluid from the third ventricle, it flows downwards along the aqueduct of Sylvius in the midbrain into the fourth ventricle. I hope now you're getting a orientation. It is secreted in the lateral ventricles. Okay, two sides which are there like this. Then it passes down into the third ventricle through the interventricular foramina. Then in third ventricle also some amount of fluid gets added. After the addition, it then flows downwards into the aqueduct of Sylvius in the midbrain and into the fourth ventricle. Okay. After it flows into the fourth ventricle, out of the fourth ventricle into the subarachnoid space through three small openings, and the central bigger one is the foramen of Magendie, which ends directly into the cisterna magna, and the two lateral ones are foramen of Luschka ending into the cisterna pontis on the cisterna pontis on the basal aspect of the brain stem. I really hope you're getting an orientation. Okay. Now, if as the CSF flows out of the fourth ventricle, it is going out by two foramen of Magendie, and that is central one. On the either side, we have the the foramen of Luschka. Excuse me. Either side, we have the foramen of Luschka, which goes into the cisterna pontis, which is present on the basal aspect of the brain stem. Okay. Next, almost all the CSF that flows upward from the cisterna magna through the subarachnoid space, that surrounds the cerebrum. From here, the fluid just flows into multiple arachnoidal villi that project into large venous sinuses and the venous sinuses of the cerebrum as well. Again, all of this, where is it getting absorbed? Eventually, it is getting absorbed into the cerebral venous sinuses, dural venous sinuses. I hope we know a little bit about cerebral venous sinuses. At least you know the names. I hope you know there is something called as cavernous sinus. I hope you know this. There is something called as straight sinus, right? All of these sinuses together will form the. I hope you know a little bit about this. So that is why I'm just flipping this through. Correct. Then finally, the fluid empties into the venous blood through these villi. So all of this fluid, they came down from lateral ventricle to the third ventricle, then the fourth ventricle through the foramen of Luschka and Magendie. They further came down, and then they further entered into these cisterns, and then they entered into this arachnoid villi. From the arachnoid villi, they emptied into the venous sinuses, cerebral venous sinuses, as well as dural venous sinuses, and then through the sinuses, through the venous blood, they entire fluid gets emptied into the venous blood. Then it comes out of the cranial cavity like any other normal fluid. Now, the movement of CSF is rather sluggish, correct? It's not as fast as you are imagining. It doesn't happen like, from third, it's coming to fourth, lateral to third, third to fourth, fourth to arachnoid. No, it doesn't happen. It's rather sluggish. But how is the movement actually happening? Number one point I told you, the cilia actually helps in it, but also it is assisted by the pulsation of arteries in the SAS or alterations of the posture. Okay. CSF is also drained back to the vertebral venous plexuses and the segmental veins. Since I'm mentioning this vertebral venous plexus, since we have already covered breast, a question to you guys. What is the percentage? Oh, okay. Direct question. What you'll have to tell me the definition of this and the clinical importance. What is called as Batson plexus of veins, and how does it affect, or what is the relation of these plexus of veins vis-a-vis the metastasis of breast cancer? What are Batson plexus of veins? And second point, what's the relationship of this plexus of veins to metastasis of breast cancer? Question. This is the homework question for you guys. Yes. Now, this is what exactly I was talking about. This is the choroid plexus of the lateral ventricle, right? From there, they are going into the choroid plexus of the third ventricle. I hope you know the relations of the third ventricle, right? You have all of this in the anterior wall. What do we have here? You will start from the sella turcica, mammillary body, and I'm not going to go any further. And the posteriorly, we have, what is this? Again, let's not. I don't want to get into the details of it. So sorry. And this is the choroid plexus of the third ventricles. From lateral, it goes into the third. Then this is the aqueduct of Sylvius between the third ventricle and the fourth ventricle. Then the fourth ventricle, this is what is the triangular space that is present here. And it opens into the subarachnoid space through two foraminas, Luschka and Magendie, correct? From the lateral, going into the third, then it goes into the fourth. From fourth, enters into the subarachnoid space via Luschka and Magendie. From here, it is getting absorbed into the venous sinuses. And this is the skull. Okay, I hope you are getting an orientation about this. Another image. From the lateral ventricle, it's going into the third ventricle. Then it is, what is this? Aqueduct of Sylvius connecting the third and the fourth ventricle. From here, it is going into the arachnoid space. This is subarachnoid space. What do we have in the subarachnoid space? Cisterns and granulations, subarachnoid granulations. Fine. Absorption of the CSF. After, what is essentially happening is it is completely covering the brain. It's kind of giving a cushioning effect to the brain. You can see clearly here the brain is getting surrounded by this in all areas, right? After bathing the surface of the spinal cord and the base of the brain, CSF passes upwards over the convexity of the hemispheres to be absorbed into the intracranial venous sinuses via the arachnoid villi, correct? Small amounts, of course, gets absorbed in other spaces like the perivascular space and the spinal veins, but arachnoid villi in itself is a 3-marker question, guys, which can come in your exam. What are these arachnoid villi? Arachnoid villi are small finger-like projections of the arachnoidal membrane through the wall of the venous sinuses. Okay, what are they? They are the small finger-like projections on the arachnoidal membrane through the wall of the venous sinuses. And it also conglomerates of these villi form the macroscopic structures called as arachnoidal granulations that can be seen as protruding into the sinuses, correct? Then these endothelial cells covering the villi have been shown by electron microscopy to have vesicular holes passing directly into the bodies of the cells. And it is also when the pressure of the CSF, right, within the, when the arachnoid villi is high. Why is it high? Look at how small these spaces are, right? These finger-like projections that you see here in the arachnoid, these are not the finger-like projections, guys. Don't get confused. This is just a gray matter. But here in the subarachnoid space, you see the arachnoidal villi. In this picture, it's not visible. Okay, do not get confused with this. Okay, these finger-like projections you're seeing, those are not the arachnoid villi. Please don't get confused. Well, now let me show. Somewhere here will be the arachnoid villi in the subarachnoid space. Okay, here. Okay, so sorry for the disturbance. Yeah, arachnoid villi are small finger-like projections in the arachnoidal membrane, and these villi form the macroscopic structures called as arachnoidal granulations that can be seen protruding in the sinuses. It's also been proposed that these are large enough to allow relatively free flow of CSF and dissolved protein molecules into the venous blood. Okay, when the CSF pressure is high, these granulations, they open up and the fluid escapes into the venous blood. So that is the reason why I'm stressing upon the arachnoidal granulations. When the CSF pressure is high, these pores open up and the fluid escapes into the venous blood. But the beautiful point over here is the venous blood cannot enter the villi. Correct? Why? Because the pressure within these sinuses are normally very low. See, the blood, any fluid always moves from a region of low pressure, high pressure, to a region of low pressure, right? So if there is any raise in the venous pressure within these sinuses, these pores close down. Correct? You have the veins over here and the pores are present here. Let's say when the venous pressure within these sinuses increase, these pores close down. When the CSF pressure increases inside them, only the granulation, only the pressure is increasing, then the these pores open, then the CSF leaks into the venous blood, right? Further, the colloidal osmotic tension of the venous blood plasma is very high, and this helps in the transfer of CSF into the venous blood. So, when the CSF is absorbed via the arachnoid villi into the blood of cranium and spinal cord, granulations, arachnoid granulations play a very important role. Till now, what have we studied? We studied that the CSF gets produced in the lateral ventricle. From there, it comes to the third, then the fourth, then it escapes into the arachnoidal space where you have this, very important structures which we call as the arachnoidal villi in these subarachnoidal space, right? And this arachnoidal villi is where exactly the CSF gets drained into, and these villi are very important whenever there is a change in the pressure of CSF. Okay, yes, this is a much enlarged picture of this, much enlarged picture, where you can see the arachnoidal granulations, and this is the venous blood. Now you can, this is the arachnoid, correct? This is the, I hope you know what arachnoid is in the first place. You're talking about meninges, right? We dura mater, arachnoid and pia mater. And in the arachnoid, you have these arachnoidal granulations. You can see that this is the venous blood. This is the venous blood. When the pressure over here increases in the veins, these pores close up. These pores close up so that there is no entry of venous blood into the subarachnoidal space. If suppose there is any increase in the pressure within the subarachnoidal space because more CSF is getting produced or anything, then the arachnoidal granulations open up and the CSF easily escapes into the venous blood. I hope now you have understood the whole point that I was trying to teach earlier. When the two parts are here, venous blood and the subarachnoidal granulations. When the arachnoid, when the venous pressure increases, for whatever reason, there may be some clot can come here and sit over here, so the venous pressure increases. These arachnoidal granulations, they close so that the venous blood does not enter into the subarachnoidal space and get collected over there. But when the CSF pressure increases here in the subarachnoidal space, these granulations open up and the CSF escapes into the venous blood, thus easing the pressure. That's the whole point that I was trying to teach. This is an important question in anatomy. Okay. Now, blood CSF and blood-brain barrier. Now, we have lot of substance in the brain, lot of toxins in the brain that can pass readily into readily into any tissues because it can pass through the interstitial fluids. But we have the presence of a barrier called as blood-brain barrier, which exists between the blood and the CSF. Thus, it prevents the entry of these harmful substances, harmful substances to the brain. These barriers exist essentially in all the areas except hypothalamus, pineal gland, and area postrema. This is a question. The regions which are devoid of blood-brain barrier. Simple 3-marker question. You will have to mention hypothalamus, pineal gland, and area postrema. Okay. These are generally highly permeable to water, carbon dioxide, and oxygen, and most lipid-soluble substances like alcohol and anesthetics and so on. But they are not at all permeable to plasma proteins and non-lipid soluble large organic molecules. That is why most medicines that we have do not cross the blood-brain barrier. Okay. Main functions of CSF. Let's look at the functions of CSF. It acts as a mechanical buffer. Imagine, guys, it's like a water bag that is sitting on top of my brain. Even when there is any concussion or anything, it protects my brain inside. It regulates the intracranial pressure by changing its normal amount in response to changes in any blood and brain volume. Of course, it helps in the drainage of metabolites. To a small extent, it may even carry nutrients to the brain, and it gives a buoyancy. Your brain is not exactly stationary. Right now it is floating inside your cranial cavity in the CSF. Okay, now what is a condition called as hydrocephalus? These are the applied aspect that I'm trying to teach. It's a condition of excess of accumulation of fluid within the cavities of brain. It can be of two types, communicating and non-communicating. In the communicating type, there is a blockage of fluid flow in the subarachnoid spaces around the basal regions of the brain, or blockage of the arachnoidal villi. What happens when there is a block in the arachnoidal villi? What happens? The CSF is not getting drained, right? So because of this block, the normal fluid does not get absorbed into the venous sinuses as it normally does. It gets collected on both sides of the ventricle as well as outside the brain, right? Non-communicating type is basically caused by the block in the aqueduct of Sylvius, right? Basically, and it mainly these are all congenital. Most of these are congenital cases when it comes to non-communicating type. And if there is any aqueduct of Sylvius atresia, that the aqueduct of Sylvius is not even formed before birth, as it happens in many babies, or let's say there is a brain tumor sitting in the aqueduct of Sylvius, what happens? The CSF therefore just remains in the lateral and the third ventricles. It's not even able to come out. This is called as non-communicating. Communicating is when the CSF comes out of the ventricles as it enters into the subarachnoidal space. That is where it gets collected. Somewhere here is the block. Now the CSF is constantly getting produced, but it is getting accumulated around the brain also, inside the brain also. But in non-communicating type, it's not even coming out of the ventricular structure, so it just remains over there. Correct? Both of these conditions will cause a raise in the ICP. However, in neonates, it will also call to head to swell, right? Because you see, in during your labor, during the labor, what happens? There is something called as molding, where the skull bones they move, around each other. The skull bones they actually they get manipulated in such a way that it comes out of the pelvic cavity. Sorry, pelvic outlet. When the head is coming out of the pelvic outlet, it obviously needs to manipulate. The skull bones get manipulated in such a way that it comes out of the pelvic outlet like this. Because the skull bones, as you can touch on the fontanel, anterior fontanel of the baby, it's not fused yet, isn't it? Because it is not fused, the head of the baby can swell. Those bones also, they start getting away from each other, and then they also start to swell. Correct? So what is the treatment? The treatment is, I can only do a surgical placement of any. Suppose I don't have aqueduct of Sylvius, lateral ventricle everywhere, the from the third and the lateral it has come, the CSF, and now it is stuck here because I don't have the aqueduct of Sylvius. I can just place a artificial stent over there, artificial silicone rubber tube. And this shunt, what happens? Then will allow the CSF to flow through. Correct? All the way from one of the ventricles to the peritoneal cavity or into the intestine. Generally, one end will be in the within the cranial cavity, and the other end will be in intestine or elsewhere where the fluid gets absorbed. Okay. Now, some important characteristics. This have just added over here as a sake of completion, which will help you for your upcoming next examination. But I wouldn't suggest you to pay so much attention or go through this again and again, because it will not help in your first year examinations. But it is good to know. It is good to know, right? Raise in pressure of any ICP seen in meningitis, hemorrhage, and space occupying lesions and hydrocephalus. Diminished pressure is seen in obstruction of CSF flow. Okay. Then biochemical tests, again, protein concentration increases as in case of any inflammatory condition, meningitis, encephalitis, multiple sclerosis, ALS, and other inflammatory, and of course neoplastic conditions. Cytological tests, normal lymphocytes about 5 centimeter, 0 to 5 cells are found. But in case of any, again, inflammatory conditions like meningitis, the polymorphonuclear leukocytosis, that is, the neutrophils increase in meningitis, whereas the lymphocytes are increased in case of TB and viral meningitis. Okay. Yes. Next, blood-brain barrier. See, this guys is actually a physiology topic, and I've just added it over here. And what is blood-brain barrier? Mainly anatomy. I'll cover only the anatomy part here. And to maintain a normal brain function, the neural environment must be preserved within a narrow hemostatic range. Blood is extremely sensitive to hypoxia, extremely sensitive to toxins as well. Because of this, it requires a very tight regulation of transportation of cells and molecules and ions between the blood and the brain. That regulation is what is maintained by the blood-brain barrier. Okay. Now the blood-brain barrier, it comprises of endothelial cells, pericytes, microglia, astrocytes, basement membranes, and tight junctions. Underline this word tight junctions, guys, because that is very, very important. Also, it comprises of all these cells, which you will study in physiology. Correct? What are in astrocytes? What are glial cells? These are all the cells that nourish the neurons. Correct? Three barrier layers contribute to the separation of the blood and the neural tissues. First layer is the highly specialized endothelial cells. That is where the blood stops, in the blood and the CSF barrier and the arachnoid epithelium. Okay. Then again, this is I just want to rush through this because this is clearly a a physiology topic. I've just included it for the sake of completion of CSF. Now we have the endothelial layer and the basement membrane, which are adjoined by the tight cell-to-cell junctions. Okay, endothelium is surrounded by the pericytes and the astroglial foot processes. These two are actually these are the layers that which will have a very tight junctions, cell to cell junctions, so nothing will pass through this. I hope you know a little bit about what tight junctions are, gap junctions are. And this endothelium, which are surrounded by the pericytes and astroglial fluid processes, also form an additional continuous stratum here. Yes, you can see in this that you can see in this that this is the blood vessel. Correct? This is the endothelium, epithelium, and here is the CSF. You can clearly see how tight the junctions are. Nothing can pass between them. This is a capillary in general. Like if I chop my hand and show you how the capillary is, this is how it is. But look at how the capillary in the brain is, how tightly it is guarded. There is no here you can see an intercellular space, but there is no intercellular space here, and it is also guarded by the pericytes above with tight junctions here. Right? Now look at this. Look at this, guys. This is what a pericyte is, and these are the tight junctions. There is no intercellular space at all. Okay. And again, I would not like to go into more details as to what are zona occludens and everything. I think this will be covered by the physiology faculty, but you can definitely go through these slides once if you want to know more about this, and as a completion for the cerebrospinal fluid. And you can definitely go through this. I've added all these slides just to just to help you to know how the transport actually takes place across this. You can use this as as a guide or as an additional thing. This is certainly extra edge material, which I would not like to go in much detail. And but to summarize the class today, what did we learn? CSF gets produced in the lateral ventricles. From there, it goes into the third ventricles. From third, it comes into the fourth. From fourth, it escapes into the subarachnoid space. I hope you've at least understood this much. Second point, raise in the intracranial pressure is what we call as the hydrocephalus. We know this. What is hydrocephalus? Raise in any intracranial pressure. What is called as hydrocephalus. Two types: communicating, non-communicating. Communicating is when the blockage is somewhere away from the aqueduct of Sylvius. It is actually somewhere in the subarachnoid space. Communicating is when the aqueduct of Sylvius itself is not there. It is commonly seen in neonates. This much we have understood. Then, third point: brain is sophisticatedly guarded by a very tight membrane, which is called as a blood-brain barrier, BBB. This blood-brain barrier is mainly formed by endothelium that have the tight junctions, which are guarded by the pericytes. Okay, so there are many things, in blood-brain barrier. I have included all of these slides here. If you want, you can just go through them once. And in the CSF, I've also included the changes of CSF in bacterial meningitis, viral, and in TB. Why do we tap CSF in the first place? Why do we even take the CSF out? Is basically to know the etiology of some of the meningitis, or etiology of what is exactly going on inside. Right? If the opening pressure is only high, that means there is increased pressure in the CSF. Okay, if there is any increase in neutrophils, that is there is something in some infection or some inflammatory processes is going on there. If lymphocytes are raised, that means it could be viral, it could be parasitic, or it could be TB meningitis as well. If albumin cytologic dissociation is there, clearly it is TB. So all of these are high end stuff, guys, but for your level, you should at least know that we do something called a CSF analysis in the first place, and that should be enough for today's class. Yes, and you can of course follow us across all the social media handles. And if you have any doubt, you can always reach out to me. I'll be more than happy to share. From tomorrow's class, we are starting the core of neuroanatomy, which is the brain stem. Okay, we'll be going in the order of midbrain, pons, and medulla. I would be really happy if you go through the class once, or if you go through the syllabus once and come, so that you can revise it quickly, and it'll help you to grasp the concepts easily. Okay, with that, I would like to conclude today's class. Thank you so much, guys, and I wish you all the very best, and keep studying. Never give up. And even if you don't understand anything, study it 100 times, you will understand. All right, I wish you all the very best, and have a happy week, and good night. Thank you so very much.